Thank you, Ralph, and welcome to everybody. So we're hoping to hold this on an annual basis, so this is very encouraging to see this kind of turnout for our first event, so thank you for coming. So I'd like to introduce our keynote speakers for this morning. Dr. Cyrus Jordan is the Director of Vermont Medical Society's Foundation for Research and Education. Previously, he served as Medical Director of the Vermont Program for Quality in Healthcare. Dr. Jordan is a graduate of Dartmouth College and the University of Connecticut School of Medicine and has a master's in public health from Harvard University. He practiced family medicine and pediatrics in inner city Boston and rural Vermont. Dr. Jordan served as chair of the board of directors of the Vermont Regional Extension Center and currently serves on the board of the Vermont Manufacturing Extension Center. And our co-speaker for the keynote is Dr. Sarah Kemble, who is board certified in general internal medicine and general preventative medicine and public health, and is a certified medical review officer. She has served as CMO of Springfield Medical Care Systems in Springfield, Vermont, and is a member of the medical staff at Springfield Hospital in Vermont. Dr. Kemble is a graduate of Smith College and Albany Medical College, and is a clinical assistant professor at the University of Vermont Medical School, and received her master's in public health from University of Massachusetts School of Public Health. Dr. Kemble was the founder of the Community Center in Western Massachusetts, where she served with a rural federally qualified health center in Western Massachusetts, where she has served in multiple leadership roles, including executive director. So please join me in welcoming Drs. Jordan and Kemble for our opening keynote speaker for this conference.
Thank you, Lorraine. So I just kind of want to get a sense of who's in the room, and maybe it would help everybody who's in the room. So how many people are direct care providers or have been direct care providers? Quite a few. How many people are, and now I'm going to show you how little I know about IT. How many people are like really on boots on the ground and write code and manage interfaces and stuff like that? And how many people here have more managerial responsibilities? And how many people here are kind of hospital-based versus non-hospital-based? So hospital-based. Okay, great. So you get a sense, Sarah, So Lorraine and Muir asked me to speak, and I kind of hummed because I don't know very much about IT. And I don't take care of patients anymore. But while I've worked on quality improvement over the last couple of decades, it's obvious that it's not going to work without IT. We need data as part of the workflow. And so what Sarah and I are going to try to do is talk about like the end game, about patient care, and kind of give you a sense of at least where the Vermont medical community is at this point. So, what I want to do is just briefly talk about this research that the Green Mountain Care Board, I'll tell you about who they are, is supporting me to do. And its recommendations, but highlight the IT part. So it's of interest to you. And then Sarah's going to talk about what it's like to practice now in a rural community, on what the pros and the cons of the IT are. So about this research effort, so how many people are from Vermont? A lot, okay. So for those people that aren't in Vermont, so Act 48 was passed, I think, 2 years ago, and please feel free when I misstate things to correct me. About 2 years ago, and this is Vermont's big healthcare reform. And you've probably heard a lot about the single payer and all this kind of stuff. But one of the big things it did is consolidated regulation into the Green Mountain Care Board, and including the authority over the state's health information technology plan, including the state's health resource allocation plan, which essentially all of CON, we're a certificate of need state. So how many hospitals, what types of services. So they also, the Green Mountain Care Board has authority over payers' rate setting, hospital budgets. I mean, they have an enormous amount of power. And that was one of the goals of the legislature, because it was kind of patchwork and nobody was really in control. So these, I was at a conference yesterday and I realized that my right and left are different than your right. So on the left, these are the state's goals signed off by the Green Mountain Care Board, the governor, the legislature for healthcare reform. And you can see they're kind of like the triple aim that came out of IHI, Don Berwick. CMS has adopted this. So it's to reduce healthcare costs and growth, access, overall health of the population, and then fairness and equity. And what the Green Mountain Care Board wants out of me, essentially, is to work and involve the direct care providers. And this first piece that I've been involved in and Sarah's been involved in has been just with the physicians. And I just want to say at the beginning, the physicians don't think it's all about them. It's really about teams. Just as much as healthcare is about IT now, and it's not going to work without IT, it's not going to work without teams because it's so complex now. But I interviewed just physicians. That's what the Green Mountain Care Board, they wanted that group to be involved. And what I did was I went around the state. There's 2 sets of interviews. And the one I'm going to talk about today is the one where I talked to the lead hospitalists in all the hospitals in the state and Dartmouth-Hitchcock. And what the Green Mountain Care Board was interested was they have authority over the health resource allocation plan. They have authority over all the measurements, ACO measurements, quality measurements, and they have authority over all sorts of payment policy and payment reform. And they have 3 payment policy pilots in the state, and they're the same as CMS. So it's kind of population-based health, ACO, it's bundled cares, and it's pay for performance. Though all the action in the world, 90% of the actions in the ACO world, there are a couple bundled care pilots in the state. There's nothing going on pay for performance specifically. So the goals, that's the goal of Act 48, or those are 4 overarching goals. The goal of my research was to, and it's ongoing, is to help them with those 3 areas: health resource allocation, measurement, and payment policy. And so used a structured interview. So essentially there were 10 questions, but this was the areas that addressed some very open-ended, most of it was open-ended questions, their biggest hopes and fears, right? And what I'm going to talk about today is just the hospitalist interviews. There's another set with more outpatient primary care people that Sarah's been involved in. But what I heard from both of them are very similar. So what are the core inpatient services in the community? What information and reports would be most useful to them? How can payment policy reform support better care? And how can we keep Vermont attractive to physicians? And I think that for those of you that are in rural parts of your state, rural care is under a lot of stress. People are having a hard time recruiting physicians. They're having a really hard time retaining physicians. And the Green Mountain Care Board is aware of that. So much of our state is so rural. And if anybody wants to know a little bit more about structured interviews, I mean, it has its pros and cons. One of the pros is it helps you get kind of nuanced, actionable information. So it's not like a survey where you already know the question you want to ask, you just want to know how many people agree or disagree. This is really like trying to get into actual details. It's kind of like a focus group. So it's same 10 questions, everybody. I interview them, I write stuff up as quickly as I can because I forget it. I send it back to them, they edit, they add to it, and then we aggregate them all. And so what we're in the process of now is, as a group, the group is seeing for the first time what everybody else has said. And they're all essentially saying the same thing. It does allow us to take kind of little pearls if we don't lose the pearls. But these 9 recommendations are basically what everybody's saying. We're going to vet this a couple more times over the next month and then make a formal presentation to the Green Mountain Care Board before Thanksgiving. And then there's a sibling, which is the outpatient interviews that Sarah's participated in. I think what you're going to say, essentially the same types of things, but more community-oriented. But so the consensus of all the hospitalists in the region are, these are the 9 recommendations. So they really feel that we need to have a health plan, a resource allocation plan for the state that's in terms of the whole population, and get away from community versus community markets competing against one another. It's just not going to work. Weight heavily patient-centric considerations. Some of this stuff is a little more actionable than others, but a lot of stuff like this is, how do you really do that? But we thought the consensus at this point is that's so important, don't take it off the table. It might be hard to do, but keep it on the table, keep it there, because it gets forgotten. 3 levels of hospital services. One of the big issues we have in Vermont is that we have the 2 tertiary care centers. So it's Fletcher Island in Burlington, and we have the Hitchcock in Lebanon. And I think, somebody can correct me if I'm wrong, I think it's 25% of Vermonters get their care at Hitchcock, and Vermont has got 40% of the Hitchcock's patients. Is that, for anybody from Hitchcock, does that sound right? And then Fletcher Island, interestingly, it's in Vermont, but close to half of its patients come from up in New York State. Is anybody here from Fletcher Island? Did I get that right?
I think it's about a third.
A third. So it's going to be difficult to create a single payer in Vermont with all these border issues, but we're going to try. But what happens at both of these, and so I interviewed the hospitals at the small critical access hospitals, the larger community hospitals, and the 2 big tertiary care centers, and they all said the same thing. It didn't really matter. What the tertiary care center hospitalists are, they're under pressure because they don't have enough intensive care beds. And what's happened as there's been kind of attrition of services in the more rural hospitals, in combination with patients who are so much sicker now that they don't have any place to send them off once they are stable. So, and it's very complicated. A typical patient would be somebody who is on a ventilator but is stable now. Needs to be on a ventilator for another week or something like that. They've got, at any one time, there are 10 critically ill patients trying to get into Dartmouth at any day. So how do they get these, still need a lot of care, but stable patients out? And a lot of hospitals don't have respiratory therapists. They might not have a lab to do blood gases. I mean, it's very complex. So one of the big dynamics that's happening is we actually need an increase in services in the community hospitals. We really need a system, and we need a system where there's much more coordination of care. We also need, so one of the big issues in rural New England is OB. And so somebody said, if you could figure out how to offer maternity care, you could really fix things. And he just uses a model. So because what's happened is most of the small hospitals, the obstetricians want at least 3 of them there. Otherwise they don't have a life. It's very expensive. Birth rate's going down. You need a full OR. I mean, you guys from the hospital world know much more about this, about the cost. So a lot of the community hospitals are doing it as a kind of loss leader, or a lot of them are doing it just because they feel like that's their mission. How could they be a hospital without, having people being able to have their children there? So how do we strategically locate OB? So the only place for Vermonters, and we don't want the only place for Vermonters to be Burlington and Lebanon to have their babies. And I'm sure people from the hospitals in the rural parts of your states are struggling with the same things. So that's what we think about. Do this strategically. Okay, we know what the population is. It's not going to change. We know what the burden of illness is. We know what resources. So can we plan for a hospital care based on what type of patients are going to be there? And can we have kind of regional centers of excellence that aren't just at the 2 tertiary care centers? Then coordination of resources goes right along with this idea of a purposeful strategic plan. View the workforce as the biggest resource, and I'm not just talking about physicians here, but in our state, workforce is in a different part of state government than the health resource allocation plan, which is in Green Mountain Care Board, and it just doesn't make sense. And then in your sweet spot, you're going to hear a lot about the trials and tribulations of the current state of IT, a lot of frustration, not only within their organizations, but particularly across the organizations. And we're not going to be able to have a regional system here without regional interoperability. Measurement, a lot of dissatisfaction with measurement. And interestingly enough, the hospitalists, they feel they want more measurement. They don't get enough information. A lot of them are hospitalists because they left primary care because of the burden of administration. So you have this irony of the people in the outpatient who are responsible for about 7% of the cost being killed by administrative burden. They're not particularly happy with what they get from it. And then you have the hospitalists who have the resources of the hospital, and they don't feel that they have enough information. And the hospitals also don't want just information about themselves. They want to know about they feel like they are part of, responsible for the whole community. So they want information about population health. They want information about patient satisfaction. They want to know how they compare amongst hospitals. Align payment logically and transparently. I think that's another thing I heard a lot about, is that, and in the outpatient one, they'll tolerate the administrative burden if it makes sense. But it does not make any sense to anybody. And actually the patients are coming in with their sore throats and saying, so what are you asking me about my BMI for? I mean, even the patients are saying, no, this just doesn't make sense, the burden of reporting. But I think transparency is a huge thing. And then finally, include the direct care givers in the policy decisions. And I think that's kind of my role here, and Sarah's role here is to, for this, the rest of the day, which will be about IT, it's what's the end game, and don't forget about the end game. And actually, probably the end game is patient centricity, and here are the people that have that human touch. So there are some other slides here, and I've touched on all this, but I thought that, so these are quotes, and I just will kind of be quiet. This is about the coordination of services that I mentioned. There's just this mismatch. And it's kind of interesting because I thought that, you talk, okay, I'll put this foot in my mouth. When you talk to the administrative and management, corporate parts of the hospitals, there is a sense of competition, but not when you get to the physicians. They know that the system needs to be redesigned. So this is interesting. IT came up, workforce and IT came up no matter what question I asked. These responses, when I asked them about measurement, I asked about information, and the first thing I word out of everybody's mouth, doesn't matter, even if there are psychiatrists in the outpatient thing, was IT. So you guys are very important. I'm glad you're all here. this probably isn't anything good to you guys. So this was about measurement. And this was what I was mentioning, this irony that they want more measurement, but and they have the resources, and a lot of them are there because they would burn out as primary care physicians. And these were some examples of the types of things that they were interested in. So, you know, somebody once told me, oh, physicians, they hate being measured. I don't think that that's the case. I think they want to be measured. They understand they have to be accountable. But it has to be measurement that is transparent and meaningful, and the return on investment's got to be there. And right now, the feeling is it's just, Sarah, I'm sure will talk much more about that. And this is more about Act 48 in Vermont. There's a lot of anxiety in the physician community. And there's another quote that's not up here about a double-edged sword, because they all see IT, the things that are bothering them most, measurement, IT, concerns about payment reform, they also see that as an incredible opportunity. So they're very supportive of reform. And so those were the 9 points I wanted to make about what I'm hearing from the hospitalists in this region. And I tried to highlight the pieces about IT. So I would like to turn it over now to Sarah, who is, as Lorraine mentioned, so she's the CMO of a very interesting organization in Springfield, Vermont, and she's going to bring us down to the patient care level as she still does patients. Sarah? Lorraine?
Another scenario.
Here.
Yep, we got it.
Show. That was the peak of my IT.
Well, thank you. Thank you for inviting me to speak to you today. It really is a joy and a rare privilege to meet with health IT colleagues live and in person. I wish I could say that I get to meet with my own crew from my own institution live and in person. I almost never do. As warm beings rather than sort of text or images on the screen, and to speak with you in our common English language. So what are the challenges and what do end users need in order to produce better health outcomes in the populations we serve? I think those are the ultimate questions, and they're great questions for this era, which is very tumultuous, and I'm grateful that they're being asked here. So first, my disclosures. I have no industry disclosures. They're almost against my religion, actually. And I'm speaking today as an individual and not on behalf of my organization, which, as far as I know, has no positions at all on any of my opinions. My expertise is in primary care, prevention, and public health, not so much in the hospital world. I have been a practicing per diem hospitalist ever since the beginning of hospitalism. And the first 10 years of my career, I practiced the old-fashioned way, going to the hospital in the morning and then the office. But I'm mostly a primary care internist, and I see patients about half-time in a small practice in Chester, Vermont, where on a normal day, I will be the only one in my office, and the days that I'm not there, my partner is the only one in the office. So, and in my lifetime, as far as IT, I've served as a clinical administrator through the due diligence phase of one community health center. And so I've talked a lot with other health center people about what it's like to make the big, leap of faith of purchasing a system. And then I've been an end user through the conversion and early implementation of 2 outpatient and 2 inpatient systems. Other than that, my last disclosure is that, like Cy, I know almost nothing about health IT, but my professional life is intimately linked with these systems. So I've thought a lot about being an end user, and I believe and hope that I'm speaking with you from a perspective that is shared by many of my colleagues in the trenches of primary care. So primary care. So the BMS study that Cy describes was really dealing with the inpatient, the really high cost centers of care. And in healthcare reform, these are the centers that receive, I'm going to say, all of the attention. But why should we care about primary care? Well, actually, all high-value healthcare systems in the world, and there are many of them, and not including ours, sadly, are built on a foundation of universal access to a basic set of preventive health services delivered in the setting of long-term professional relationships, primary care. And where universal access without any barriers to primary care exists, health outcomes are superior and total costs are lower. So access, quality, and cost, that's the triple aim. So some background on the U.S. primary care setting in which our health IT systems attempt to operate. Primary care is really suffering. The main reasons for this are economic, pure and simple. Primary care is by far the most intrinsically rewarding medical career choice, and I say this in all objectivity. Therefore, if it were not for the strong disincentives for doing it and doing it well, the primary care shortage would actually go away. It is a critical part of our system that, in spite of being horribly overburdened, what remains of it works rather well. There just isn't enough of it to go around. I would propose, and I often do, that the primary care system doesn't really need to be altered. It just needs to grow. And so it's one problem that really could be solved by throwing money at it. Primary care physicians, so because of the economic burdens, basically all the problems kind of flow out of that. So we're an aging cohort. I'm 55, and I may still be a little bit below the average age, and maybe I'm a little above, but I'm right around the average age of primary care internists now. When we're studied, primary care doctors as a group are found to be discouraged, depressed, and burned out. Disparities between their workload and income of primary care versus other medical specialties has produced a situation in which very few physicians are entering the field, and those who retire are not being replaced. There are estimates that the upcoming Meaningful Use and ICD-10 deadlines may actually accelerate this process as older but still in their prime primary care docs are driven out of business. The U.S. payment system favors high volume and technical services over the old-fashioned virtues of spending time with patients, getting to know them well, and with this combined clinical and personal knowledge base, being able to exercise the judgment and restraint, importantly, that is the foundation of high-value healthcare systems. All the stressors in the primary care system are especially felt in rural areas, such as ours here in northern New England and any rural area. Actually, in New England, small and solo practices have formed the backbone of primary care for decades. And now, so the fragility of this primary care network and the community hospital network also in rural areas cannot be overemphasized. So as Cy was also iterating to you, and I am reiterating, most primary care practitioners will tell you that so far the costs of their electronic systems exceed the benefits. The economics of the electronic era have been not kind to us. In an era of declining reimbursement for all medical services, primary care practitioners now perform the lion's share of data entry into our EMR systems. And by some estimates, there's an ongoing cost of $20,000 per practitioner per year. Not that we don't appreciate the potential benefits, but because of this disconnect that I'm about to talk more about in detail, the disconnect that still exists between the data in our systems and then the work of individual practitioners in practice, the cost and the benefits are not yet matching up. So a little more of my own story. Like most primary care doctors, my training took place entirely in the paper era. Contrary to what some might think, excellent clinical care was always possible and was often even received by patients back in the old days. I myself worked very diligently for many years in the community health center that I founded in Franklin County, Massachusetts, to create a user-friendly paper record system. And this system, importantly, consisted not just of the paper, but of paper and the people interacting and creating systems so that relevant patient health information would be accessible during all patient encounters within our practice. And I think we achieved very good success, at least by the standards of last century, where the measurements only counted within one organization. And at that time, the fax machine was like a revelation to us that we could transfer information outside of our system. That wasn't that long ago either. So the first time I experienced a paper to EMR conversion was in a community hospital about 10 years ago, and it was more or less of a bloodbath. There were casualties. There were very experienced nurses and physicians who chose to retire early because they did not want to go through it. And they never looked back either. They were not told by their friends after they retired, oh, it wasn't so bad, come on back. They were gone. At the time, those of us who didn't survive, we were clinging to the belief that this would be a one-time ordeal. How quaint. How quaint is that? Of course, it turns out that learning how to learn whole new electronic systems, or at least keeping up with major life-altering upgrades, is now a medical skill that is every bit as critical as knowing which end of the stethoscope to put where. So we think of the costs of electronic records not only in terms of the money, but the time. And this will not ever change. For clinicians, on the other side, the benefits. For clinicians, health IT offers two major and powerful potential benefits that we only dreamed of in the paper era, but we did actually dream of them. Back in the day, only health researchers could tell us what was going on at a higher level than at the level of individual patient care. And we are very avid for true, valid information about clinical practice so that we do a better job. A couple of examples. I was personally devastated as a young primary care physician to learn the overwhelming data coming out of the Women's Health Initiative that the hormone replacement therapy I'd been trained to prescribe for all postmenopausal patients had probably killed some of them. My practice turned on a dime when I learned that. And likewise, the overwhelming evidence that harms far outweigh the benefits of routine prostate cancer screening in men without symptoms was a game changer based on the data. And you don't have to do anything other than present us clinicians with data that we trust, and we will take immediate action because that's what we do. We care about our patients and we don't want to hurt them. Our system is suffering from enormous healthcare disparities and very perverse economic incentives. So we kind of have a dual challenge. We do have a dual challenge. How to deliver, on the one hand, evidence-based necessary care to the underserved, and to refrain from unnecessary and harmful care to the well-insured. We actually err in both directions, over-treatment and under-treatment for different segments of our population. And good data at the right time can help us to level the playing field, do good prevention work, and avoid costly over-treatments. And a lot of the excess cost, some researchers would say the majority of excess cost in our system is due to unnecessary and harmful care. And so it is up to us as clinicians clicking the mouse on orders to refrain and also to our systems to refrain. So how do we do that? It's really hard. So the first promise of a robust health IT system is the ability to aggregate data into useful, timely reports that will allow us to understand what we're doing in the first place. When we're able to do this with confidence, ease, and in a timely way rather than 18 months or 2 years after we did what the data is based on, this will guide our clinical decision making and support our work, and we will do the right thing. I think a lot of people outside of our healthcare industry believe that this is already happening, but as we know, and I can tell you for sure from the trenches, we are not yet there to achieving the true linkage that we want between clinical medicine and population health in a way that is meaningful to daily practice. The second promise of our new era is that clinicians should be able to have access to all relevant health information at the precise moment when it is needed for patient care. Information exchange is much better and faster than it used to be, for sure. But we now have created some additional new problems that we really didn't have before. One of those is privacy. And another is that really the timely delivery of relevant data is still not happening between systems, and especially there's a big problem with automatic functions between and within individual systems that are driving a lot of unnecessary care and duplicative care. So meaningful use in patient-centered medical home payments do actually help to defray some of the costs of the new era. However, they don't fully cover them, and they in themselves generate the need to spend more resources on meeting those criteria. The payers are now punishing us financially based on administrative claims data to which they are entitled, as well as protected health information to which I would respectfully argue at this point they are not. Years after implementation of electronic health records, we actually are beginning to see some successes and advances in our clinical understanding of patient safety in the hospital setting. But the gains have been smaller and much more difficult to achieve than we ever imagined or hoped 10 years ago. The gains are very hard fought and have been very expensive. And in the primary care realm, we have barely begun the journey of valid, data-driven quality improvement. So I'm just going to run through a few of the issues that, this is not a complete list. This is the list that I personally came up with and talked with a few colleagues about after being invited to give this talk. So take it for what it is worth. The first issue is data quality. You saw one of the quotes from the hospital study. In general, providers do not trust data. They just don't, because they've received so much of it, and they've noticed that each report seems to tell them a different story, and some of the stories actually contradict each other. So there's this logical thought process that therefore, at least some of the data we are asked to pay attention to must be false. And therefore, if some of it is false, all of it might be false. And having been scientifically trained, most providers actually can understand when we have this conversation, which we do a lot as we're trying to struggle with our quality measures, that every report is 100% correct and valid if you take the time to understand how that data was collected and entered and constructed into numerators, denominators, and trends. However, primary care practitioners don't care. what they need and want is consistent, transparent, and comparable data that they can actually put into service of their patient care. Attribution. All high-value healthcare systems in the world are built on the foundation of a large primary care infrastructure and appropriately scaled, geographically correct secondary and tertiary care referral centers. This obviously is not what we have in the U.S. at present, and even here in New England, although we are ahead of the curve, and in Vermont, our primary care to patient ratio is the best of any state in the United States. We still suffer from undersupply of primary care. Nonetheless, we are attempting to gravely move ahead towards population health using the various ACO payment pilot methodologies. And these are all based on correct attribution of patients to specific providers. Likewise, within practices, getting to know who your panel actually is absolutely fundamental to understanding what you're doing. At the practice level, it's the first requirement that the health IT systems simply tell us who our patients are. Patient attribution is surprisingly weakly built into some of our systems, many of our systems. And reviewing some of the early data on the panels from the ACO that I participate in, we know that the attribution is just not right. It's not quite right yet. And that's based on claims data. So I don't pretend to understand what's wrong with it, but we know that there are flaws in that system. From the standpoint of many primary care end users, this creates a complete disconnect between any data at all and relevance to themselves. So valid patient attribution is the most fundamental operation to our ability in primary care and in public health to understand the demographic makeup and clinical and financial performance of individual practices. The quality measures. The measures themselves, as Cy collected all of that data from the hospitalists, we want quality measures that are valid, but the different entities that measure quality for us that we have to report to often tell us to construct these the numerators and denominators in different ways. In the community health center world, just one example is that when we crank the numbers for the uniform data system, which is our reporting up to HRSA for our community health center grants, and the same data under meaningful use for something that you might think is simple, tobacco status of patients, we actually end up with radically different results. And so one of them may show us that we're doing a fantastic job, and the other one shows us that we are terrible. And it's just because of how those data points are, how we're asked to measure them. And providers have no idea, of the content of how those are constructed. And when they see something like that, they just think we can't act on this. We want to, but we can't. Another thing that has happened in our system with the meaningful use criteria is that because we have about 4 different systems in we're integrated clinically in Springfield. We have FQHC Corporation, that's the parent of the hospital and of the psychiatric hospital. So we have. But we have different systems, different IT systems for the inpatient, for the ER, for the lab, for the outpatient, and they don't talk to each other. So the humans that are trying to interact are actually having to meet meaningful use criteria in all these systems, and the inpatient physicians used to do this fabulous job of medication reconciliation using the outpatient system, so that when the patient would come back to the office, we would have an updated medication list. Now they have to spend so much time just bringing the inpatient system up to meaningful use criteria around med reconciliation. They don't have the time to do that anymore. So they have told us that the MU criteria actually have decayed the quality of care that they're able to give to the patients. And they're quite distressed about that. So those are just a couple of examples. In measuring and recording our data right now at this stage of our game, we measure at the corporate level. So, and corporate level reporting does not translate into usable reports for individual practitioners or patients. Most quality reporting methods involve the use of a small number of randomly selected patient records, attributed not at a practice level, but at the administrative or billing entity level. And so these data points do, in fact, generate high-level and entirely valid results, overall results for the corporate entity, but again, there still remains that disconnect between what the corporation is doing and then what we're doing on the ground with our patient care. And the data that we put so much time and effort into sending out to our payers, it ends up being almost entirely useless to the individual practitioner. Interoperability, the holy grail. There's so many examples of what we have to do better if this is ever really going to happen. Med reconciliation is probably the prime example. Health IT systems are really designed to support the addition of new diagnoses and orders. They subsequently promote and encourage repeated operations that have been done before. And they support new operations, but it is really not in their nature to allow any past function to ever fully fade away or go away for any reason. So this leads to a host of errors, of duplication errors, and of repetitive errors, including the system has a great difficulty in recognizing when drugs have been discontinued. So this is not the only issue of interoperability, but this is, to me, a very key issue. Duplicate drugs on the medication list in the form of both generic and brand name products is a huge issue in med reconciliation. Now, since numerous users are always able to add drugs to a patient's list almost at any time, we have come to understand that at this point, no one can ever guarantee that they have their hands on a true gold standard med list with absolute certainty. That's a scary, scary fact. One issue related to med reconciliation that's especially difficult and contributes a huge amount to unnecessary costs and serious patient safety concerns is the automaticity built into pharmacy and clinical practice systems and a lack of interoperability and feedback when drugs have been discontinued. So, as you know, every day pharmacy systems are asking clinical systems to refill thousands of drug prescriptions that were written in the past, originally were written in the past, and they do so without access to updated data on adverse drug reactions, on dosage changes, or discontinuations, usually for very good reasons. The pharmacy systems, I think, never receive, correct me if I'm wrong, complete medication lists. Maybe they do sometimes, but in my world they don't, and they never have. And they do not participate in medication reconciliation. They just fill new scripts. Many community pharmacists, we do have a little roundtable working group with our community pharmacists, and we know they are in distress about this as well. They know they're doing harm and they don't know when they are. And they would be very happy to participate in medication reconciliation, but they do not have access to the correct data at the right time, at the point the fill of those prescriptions. Large retail chain pharmacies, and especially the mail order pharmacies, generate automatic refill requests on every medication that they ever filled until expiration of the original prescription, basically no matter what. And then they actually stimulate the patients to come back and ask for a renewal of that refill of that drug even after it expires. So there's just this driving force to keep all drugs going, and nothing like it that helps us with discontinuation. It's all too easy and common for meds that were previously discontinued to be erroneously restarted in our own systems based on an automatic refill request from the outside. Indeed, this particular type of med error is just built into our current health IT systems and is a new type of medical error in the electronic era. And we know from the Institute of Medicine that medication errors kill 100,000 people a year, and that polypharmacy of elderly patients is a major, major quality issue. So while we're measuring and reporting all these wonderful measures, and I think we do pretty well often to the payers on a corporate level, at this individual level, there's a lot of problem in quality and safety of patient care that we are not supported in, that is actually made worse by IT. So I had more words written here. I think I've made the point. Really, discontinuation, we've actually worked with our local pharmacy guys to figure out ways to use our IT system in ways that it was not designed to be used, but to send them code messages with actual refills when we're actually discontinuing, so that we actually do tell them when we're discontinuing a med. But I don't think that's the answer, because it takes way, way more work, way too much work. And then it looks like we're actually sending a prescription for one pill one day, and then we write on the label, please discontinue. You know, that's our smoke signal to them, really, that we're discontinuing, and then we discontinue it in the system, because after the drug's discontinued, it no longer will leave. And the designers thought, well, there's no need for interoperability after you discontinue a drug, you're all done. So communication of discontinued drugs or of a complete medication list across and between systems is mostly a non-automated function now, and has to be still done the old-fashioned way, by hand, by phone, by smoke signal, however, and is performed by humans who have to actually override their own IT systems. Privacy. I'm not even going to go there today. Maybe some other time, right? So in conclusion, these are the issues. Data quality, we have trust issues, and we're not paranoid or insane. They're based on experience. Attribution, the basic fundamental unit on which all else is going to be built. The measures themselves, technical people cannot help us with this. These are kind of clinical dogfights that have to be fought. What we really need agreed upon norms for operational definitions of these measures, and then we need to all agree where the data goes, where it's entered, so that when we're reporting out of the systems, we get comparable reports. Corporate level reporting, it's great, but useless in practice. And interoperability, I don't know if it really is a real goal that we ever will achieve. Honestly, if we had a perfectly interoperable set of systems, we would have a single system, right? I don't know. But in our healthcare system, we have made the political choice so far to prioritize the health IT systems as basically profit-making corporate ventures, rather than as part of a public utility healthcare system. And privacy is another whole discussion. So really, I know you guys know that it's a myth that technical solutions alone will solve all the problems of healthcare. I know that we're on this interesting journey together. And as the technology matures, I have every hope, really, in spite of all the whining I've just done, that we will reap incredible benefits that remain mostly still potential today. And I'm confident that we will resolve the unintended consequences, including many of the novel problems that have come up and been caused by health IT in the new era. Because actually, any system needs the human and the technical component, and healthcare has always been that way. If a system bought, a scalpel or a fancy new piece of equipment, it still needed human beings to know how to operate it with skill and judgment. And the same is true with health IT systems. It's just the newest fancy medical instrument. It's the most expensive one we've come up with so far, but that's what it is. And it has to interact more appropriately with the human aspects of the system to really deliver on the goods that it still does promise us. So, thank you. I look forward to hearing more discussion.
We've kind of used our break, which basically is putting us pretty close to on schedule, but I think we've got a couple minutes for questions if anybody has any questions for either Dr. Jordan or Dr. Kemble. Yes.
So, for Dr. Kemble, I really appreciate your honesty in sharing with us some of the issues that you found in implementing systems. So if you had the ear of all the CIOs, of all the CEOs, of all of the EHR and HIE and all those companies in this room right now, and you were able to give them 2 or 3 words of advice about what they should do. I recognize some of these things are not fixable by them, but more the system, and they can't fix that. What words of advice would you provide them to how you think that they could change the systems so they become more effective and efficient for you providing care to your patients?
I think things that actually can be done right now have to do with management systems in the organizations, where the premise that health IT is some kind of new thing rather than just another kind of medical instrument that's got to be used the right way has meant that the IT part of organizations has grown as a silo, kind of, rather than being having adequate communication with the clinical side of the operation. So I think a lot of times senior management makes decisions really without adequate clinical input, and that's how the management structures are constructed. I mean, it's sort of a human part of the human condition to feel like we're always left out and abandoned and stuff. But it's not personal, and everyone's really doing the best they can. But with a management structure of clinical and IT being so separate as they are, I think that creates a lot of everyday problems that would be pretty easy to deal with if people talk to each other, kind of at the right time. And if there was one thing that I would advise everybody in their own system to work on as a priority, it would be this attribution issue. And maybe it's just the systems that I've been in contact with and suffered from, and maybe other systems know how to get it right. I don't know. But I think attribution is so fundamental to getting clinical care right that is something and that's something that has to be done at the local level, within each system.
Anyone else? Okay. Thank you very much, Dr. Kemble. So we're